Hello, I'm Thomas Desmettre. I have a private retinal practice in the north of France, in Lille, and an academic appointment in the Department of Ophthalmology in the University of Kansas, in Kansas City. 3 years ago, I purchased the Mirante primarily because of its excellent color fluorescein ICG autofluorescence imaging. I was also intrigued by the retro-mode imaging technology, and I wanted to explore its clinical value. I have the great privilege of working with Professor Martin Mainster of the University of Kansas, who was one of the inventors of the SLO over 40 years ago at the Skippen's Eye Institute in Boston. So together we have explored the retro-mode optical physics and clinical applications. The Mirante is a multimodal imaging device that combines an SLO and an OCT. It allows you to obtain multicolor images as well as fluorescein, ICG and Geographic. You can also choose between blue and green autofluorescence imaging. Mirante provides structural OCT and OCT and Geographic imaging. You can obtain ultra-wide field images by attaching an external lens to the device. And the Mirante is the only currently available clinical imaging system that offers retro-mode imaging. Most standard wide-field SLO systems use a small confocal aperture, a pinhole, to capture light reflected directly back from the fundus. This type of imaging is referred to on the Mirante as direct confocal mode. The Mirante also provides 3 additional imaging modes by shifting the confocal aperture on the right or to the left, or replacing it with a ring aperture. You see that the DL and the DR retroillumination modes can provide striking illusion of depth, making it possible to highlight subtle elevations associated with retinal or subretinal pathologic structures. So today, first we will outline how retro-mode works, or how we think it works, and then we try to see a few cases. Most of us started using fundus camera system, which capture both back-scattered and side-scattered photons. This system uses a flash. Conversely, SLO provide high contrast, high resolution images by using this centered confocal aperture to image only back-scattered photons and reject the side-scattered ones. Depending upon the laser that you use, you can get blue, red or green light images or color images that is a combination of them. For the retro mode, if the pinhole is deviated on the left, only photons scattered in a certain direction will reach the detector. Lastly, with a ring aperture, you see that most of the side-scattered photons reach the detector, while the back-scattered photons are blocked. We can start with a few cases of early age macular degeneration and see how retro mode helps to disclose drusen pigment changes. This patient has a neovascular AMD in the right eye, and here on the left eye we display serous drusen and some pigment changes. As we can see here, the drusen are very well displayed on the DL or on the DR retro mode, but the pigment changes that we see here on the autofluorescence are a bit hard to disclose on these pictures. On the contrary, ring aperture retro mode identifies pigment changes better than on the DL and the DR mode. Here, DL or DR retro mode detection of reticular pseudodrusen seems even better than for serous drusen. On this non-vascularized drusenoid PED, irregularities of the RPE are very well disclosed here, but you see that the DL retro mode fails to show the lack of homogeneity of the material that helps to make the diagnosis and is very obvious on this OCT here. On the other hand, you can see that orange pigment that may be lipofuscin is displayed on the autofluorescent as well as on the ring aperture retro mode. Now for our geographic atrophy. This patient still keeps foveal sparing. We notice serous and refractile drusen, and while the DL of DR retro mode allows the detection of the serous drusen and demyelination of the geographic areas, Ring aperture retro mode shows pigment clumps within the foveal sparing. Later on, it's not surprising to see the evolution toward an enlargement of the geographic area. Now for pathologic myopia. Here the case of a 60-year-old male with myopic macular retinoschisis well displayed on the OCT. But you see that on the DL retro mode, we see the extent of the wrinkling due to the schisis. For neovascular AMD, for retroretinal interface conditions or central serous choroidopathy, retro mode will show the elevations of the retina due to edema, retinal serous detachment, or pigmentary epithelial detachment. And this helps to make the diagnosis, but maybe in this situation, retro mode doesn't bring very specific characteristics. We'll finish this presentation with choroidal nevus. This patient has had choroidal nevus for almost a decade. And you see here how the ring aperture retro mode shows the limits of the pigmented lesion. Interestingly, the size of the nevus here is congruent with what we measure on the choroidal slab of OCT and Geographic. This 50-year-old patient has no visual complaint. She's just referred because of a big optic nerve on the left side. Of course, it's just optic disc drusen with a spectacular image on the retro mode here. So to conclude, how does it work? I'm not sure we know exactly how it works, but it seems like retro mode triggers our perception of shape from shading. On these two inverted drawings for practice. First, it may be hard to foresee what retro mode aperture, DL, DR, or ring aperture will be the most useful in a patient's assessment. So most of the time you will have to do the free. In most cases, DL and DR display very well the subtle elevations of different types of drusen. Then retro mode helps to detect choroidal nevi with a characteristic pattern, even for cases not visible on the other image like infrared. For pigment clumps, geographic areas, lipofuscin skin deposits, all these seem very well disclosed on the ring aperture. The main limitation of the technology is the absence of real 3D information. Thank you for your attention.